Hello and welcome to my revision video for the Psychopathology unit. I'm going to start by going through the 4 definitions of abnormality before I go on to then talking about phobias, depression and OCD. Nice and cheery stuff. So to begin with, we've got the 4 definitions of abnormality, which are statistical infrequency, deviation from social norms, failure to function adequately, and deviation from ideal mental health. So we need to know what each of these things are and some sort of evaluation for them. So to begin with, we've got statistical infrequency. It is, as it says on the tin, it's where individuals are deemed to be abnormal, and when we're talking about abnormal here, we're talking about having a mental health problem when they fall outside of standard statistical norms, so outside of averages and standard deviations. So on a frequency graph like this, what we'd say is anyone at the extreme ends, they would be deemed to be abnormal. So take, for example, mood. So if you are very, very low on mood, if you're down this end, on mood, you'd be seen to be depressed, and if you're at this end, you'd be seen to be manic. Anyone kind of in the middle would be seen to be, in inverted commas, normal. So that's the statistical infrequency model. So anything that's statistically rare would be deemed abnormal. So evaluations for this then. Well, one of the most important things and one of the biggest issues is that not all behaviours and thoughts that are abnormal are necessarily bad. So think of, maybe go back to that frequency graph, maybe you think of intelligence. At the very high end of intelligence, actually that's seen as a good thing in lots of societies, as well as that anxiety. So think at the low end of anxiety, that's seen as a positive thing. So just because it's statistically not average, then doesn't mean it's a bad thing. Also, there's an issue with where do we make the cutoff? Where do we say, right, this part is normal and this is abnormal? And that's going to be arbitrary. A person is going to have to decide that cutoff point. And the problem with that is it's going to be based on someone's culture, and there's going to be biases involved in who decides and where they decide the cutoffs are. The other issue as well is some behaviours are not rare but are abnormal. So there's the Rwandan genocide, so people committing genocide at that time in that place, they would be statistically frequent, but that's not necessarily a good thing. And again, Nazi soldiers who were carrying out the orders of the senior members in maybe Auschwitz, again, that would be normal, but it's not a good thing. So there are some issues with the statistical infrequency explanation of abnormality. Next, we go on to deviation from social norms. So where statistical abnormality or infrequency looks purely at numbers, as it says on the tin, deviation from social norms, this is more to do with what's acceptable in the society and conformity and things like that. So we've got desirable behaviour to the individual or society. So anything that's seen as maybe undesirable for the individual or society, that can be seen as a deviation, and that will be what's defined as abnormal and potentially a mental health issue. So yeah, you've got individuals labelled as critically abnormal if they act in antisocial ways. So someone who acts very aggressively and has no guilt about that, that would be, for most cultures, seen as abnormal, and would be, you would either get diagnosed with a mental health disorder, or you'd certainly end up in prison if you committed those sorts of acts. Again, there are evaluations here. So morals and norms are subjective, and they change. They change between different cultures. They change between at times. So you've got unmarried mothers, highly stigmatised at one point in Britain, but nowadays not as much. Certainly, they won't get taken away from their families and their children taken away from them, which used to happen. Again, non-conformists in Russia. Homosexuality used to be a mental health disorder up until the 70s because it was seen as societally unacceptable. And again, things like that have changed. So there's an issue here. It's not as hard and fast just saying it's acceptable in society. Well, society's changed and society's views change. And context is really important as well. So one behaviour, so the behaviour, for example, of wearing a bikini, in one context that's fine. So for a woman at the beach, that's fine. But for a man down the high street, generally you'd probably get some funny looks and not be seen fine. And before I get any woke feminists, I don't think that all women have to wear a bikini at the beach. And Also, social deviance is not necessarily a bad thing. So again, going back to the example in the Nazi Party, those soldiers who refused to carry out the actions or helped Jewish people instead, that would be deviant, but would be deemed as a good thing. Again, in a different culture, maybe at a different time. Martin Luther King at the time, there's a saying that goes that what one person's terrorist is another person's freedom fighter, because at one point they're villainized until things are changed. Also, sportsmen. So you get elite sportsmen. They tend to go over and above. So Johnny Wilkinson was known for training for hours and hours and hours and hours. That would be socially abnormal, but it produced good outcomes. So just because it's not normal doesn't necessarily mean it's a bad thing. The next definition of abnormality that you need to be aware of is failure to function adequately. This suggests that people are abnormal or have mental health problems if they can't function in life, if they can't have a meaningful, successful life, not functioning how they should. For example, Rosenham and Seligman suggested characteristics that would be ideal, and so obviously would be functioning adequately, and so if you're not hitting these functioning adequately, then you can be seen to be abnormal. So they are suffering, not suffering from suffering, maladaptiveness, unconventional behaviour, loss of control, irrational beliefs and thoughts and actions, observer discomfort, bit of a controversial one, violation of moral and ideal standards. And the idea here is that it's not just any one of those things, but a combination of them, and the more of those things that you have, the less likely you are to be functioning adequately, and therefore the more likely you are to be abnormal. Issues here, again, these are very subjective. Who's to say what's normal or not, what's adequate, what's good functioning, and what viewer distress, that could be quite a subjective view. What one person sees as distressing behaviour to observe, another might not, and so that's another issue there. People are not always aware of their failure to function adequately, so there are some mental health disorders where people are unaware they're suffering from something, and it may seem perfectly normal to them. So for them, they're functioning adequately, they're getting on with their life, but actually it's other people that have got a problem. So where do you draw the line there? And the kind of strength here, the benefit is that actually this is there is an outcome here. You can see that if someone isn't holding down a job, isn't able to have successful relationships, isn't able to go out, that would potentially be seen as a problem. It's a problem for them as well. There have been lots of studies that support the fact that leads to negative outcomes in life, and potentially people suffering from harm, and suicide, and that's obviously a poor outcome. And so not hitting these adequate functioning does have a distinct tangible outcome. The last one then is deviation from ideal mental health. This is meant to be quite a positive view. So we've got Maslow's hierarchy of needs, which hopefully you've looked at in the approaches topic. And then you've got Jehoda came along and said, well, actually, if people aren't able to hit those needs, so survival, safety, love and belonging, esteem, self-actualization, then that's when they're having issues. So yeah, Jehoda would say that if people can't strive towards being autonomous, being independent on their own, having high self-esteem, having mental strength, being able to deal with setbacks, that would be a definition of an abnormality. Obviously, reminding ourselves of what Maslow's hierarchy of needs is there. But again, this is a really difficult one. For me, I'm not keen on this one. Very, very few people can actually say they're self-actualized the whole time. So according to this definition, that would then mean that everyone's abnormal and everyone's got issues, and that's just not the case. And as well as that, this is quite a Western cultural view. So other cultures have different views of what it is to be successful, less individually focused, more collectivist. And actually the idea of it's quite individualistic, all out there for yourself. It's all about your goals and your striving is quite a US phenomenon, really. For the next part of the psychopathology topic, what we need to do is go through phobias, Depression and OCD look at the characteristics of them, the behavioural, cognitive and emotional characteristics of them, look at an explanation for them, and look at some treatment for them. So we start with phobias and looking at their behavioural, emotional and cognitive characteristics of phobias. So what is a phobia? A phobia is defined by the behaviours of panic, crying, screaming, running away, avoidance, sometimes though endurance, so remaining anxious and in a panic state, but being very wary of a particular event or situation or object. The cognitive side of things looks at selective attention, so this is where you kind of pay attention to things in the environment and pay maybe more attention to the things that you're scared of rather than not. Irrational beliefs, so thinking things are more likely to happen than they actually are, thinking that just seeing an everyday spider that has got no chance of harming you could potentially kill you, and cognitive distortions, believing again that catastrophizing, believing the worst possible outcome is going to happen. So this is quite a cognitive, that's the cognitive side of the phobias. The emotion that leads to, well, a phobia is an anxiety disorder, so it leads to heightened states of anxiety and distress and upset, and there tends to be an excessive emotional response. You can generally tell that someone is anxious of a particular thing when they're presented with that. As I say, it could be spiders, could be clowns, could be whatever it is that people are afraid of. There's any number of things that people potentially can get phobias from. How do we explain phobias? Well, one explanation is the behavioural explanation, and it's from Mora, known as the two-process model. And the two processes come back to, again, from approaches looking at classical and operant condition. And it can be suggested that we might develop a phobia through learning. So we learn to be scared of spiders or snakes or flying or whatever it may be. The two processes refer to the fact that you could maybe learn to gain a phobia through classical conditioning, so that is where you acquire the phobia from, and then you maintain it, you keep that phobia due to operant conditioning. So the important study here is Watson and Rayner and the study of little Albert. This is where a little toddler who didn't have any fear of white furry things was caused to have a phobia by John B. Watson, so quite an unethical study. And so what happened was that the infant little Albert was presented with a white rabbit, and at the same time they banged a big metal bar which scared little Albert. That's natural. So in that situation, the noise, the banging of the bar, would be the unconditioned stimulus. Being scared of that bar would be the unconditioned response. To begin with, little Albert had no response to rabbits. He was a little child, so rabbits didn't mean anything to him. But if you pair an unconditioned stimulus, in this case the noise, with a neutral stimulus, in this case the rabbit, you produce the unconditioned response, which is fear, until eventually little Albert fears rabbits. So you can then imagine that being applied to lots of other things. So people, again, a child, the first time they've seen a snake, that might not mean anything to them, but if they're pairing that with unpleasant outcomes, it could be their own fear, it could be screams from other people, then they're learning, they're acquiring a phobia through that. The idea is then this two-process thing. This is then maintained through operant conditioning. What does little Albert do after seeing the rabbit? Well, he avoids the rabbit, doesn't go anywhere near rabbits, he screams and he stays safe. Nothing bad happens, he doesn't die, he doesn't have any bad outcomes. So that behaviour is reinforced. Next time that you see a rabbit, you think, okay, well, last time I ran away or I was scared and nothing bad happened, so actually I'm going to maintain that behaviour. So you've got this vicious cycle of the phobia being acquired through classical conditioning and then maintained by reinforcement through operant conditioning. Quite a nice, neat theory. I do like this theory. Not all perfect though, so there are some issues with it. Firstly, there is a strength here, and we'll go on to looking at this. So if we've got this theory that we've learned to have a behaviour, well, if you've learned something, you can unlearn it, you can go back on that, and we'll look at CBT. And actually CBT has been found to be quite successful for phobias, as well as flooding and systematic desensitization, both of which are behavioural treatments, and they do seem to work. So the fact that you can unlearn this behaviour adds weight to the theory of it. So that's the first strength of the theory. The one weakness is the fact that avoidance isn't always necessarily a bad thing. So actually, if you are near a poisonous snake or spider and you're scared of those things and you've avoided it, well, actually you just saved your life potentially. So viewing avoidance as a negative outcome, not always correct. The biggest problem for me is the fact that actually quite often people might be scared of things that they haven't had any direct response to. You might not have had a negative experience yourself with a spider or a snake or a clown or whatever it may be, yet you're still scared of them. What's probably happened there is you've observed other people. You've watched siblings or parents, or you've seen it on TV where other people are running away or screaming or scared of these things, and you've watched that behaviour and you've mimicked it. So that's slightly different. That's indirect. That's social learning. And so that can't be explained through Mora's theory because that requires direct learning. So that's a problem with the two-process model. It also ignores evolutionary explanations, and if you care to go into more detail about phobias, they can be seen as evolutionary advantageous. Again, if you're scared of things that legitimately can kill you, then you've passed on those genes and it provides an adaptive advantage. And the behavioural theory on its own, Mora's two-process theory, again, it kind of ignores that, doesn't take it into account, and so that's an issue with the theory on its own. But it does explain it does explain the behavioural side of phobias, which is great, and there is certainly a behavioural side to it. But as explained in the characteristics, there's also a thinking side. It's quite a mental, cognitive aspect as well as being potentially biological. And so by just focusing on the behaviour, you're ignoring those other factors, which again is an issue. Looking at the treatments then, so if you've learned to have a phobia through classical and operant conditioning, then the theory is you can unlearn it, and there are two methods that you need to be aware of that can do that. First is systematic desensitization. So this is where you counter condition. So through pairing an unconditioned stimulus with a neutral stimulus, you've conditioned two things together. Well, you need to kind of uncondition that. So there's a way of doing that. First, you'd create a fear hierarchy. If you're scared of going on flights, if you're scared of going on a plane and you want to go on holiday, well, what you would do is create a fear hierarchy. So having the least fearful thing up to the most fearful thing. So the least fearful thing might be seeing a picture of a plane. Then it might be seeing a video of a plane. Then it might be actually being at an airport and then being on a plane and then flying. So you've got this hierarchy of least fearful thing to most fearful. So that's the first step. What you then do is learn relaxation. So you might learn breathing techniques. You might learn to condition each stage with a better outcome. So thinking of happier thoughts and relaxation and being in control, muscle control, all of those things add to relaxation. What you then do, third thing, is exposure. You would go through the fear hierarchy. So you would get a stage where you see the picture of the plane, and that might initially cause maybe an increased heart rate, a bit of panic. So you then practice the relaxation techniques until you're comfortable with viewing a picture of a plane. Then you work up the hierarchy. So next you'd do that with a video. And again, you would probably start at the video and it'd be scary, but work through it, relax, and you get better. You could then be at an airport and then potentially be at a plane. And that's the idea of systematic desensitization. So it takes time, it requires input from the patient and a therapist generally, but it does work. Flooding, on the other hand, is kind of that without developing the fear hierarchy. So you're just put into the situation that scares you. If you're scared of spiders, right, go and hold a tarantula. And that would be really, really upsetting and discomforting and not a pleasant thing to do. But if you were in a situation where you then couldn't leave, eventually you would get so used to being in that situation, and if it was maybe a defanged tarantula, you would be okay with that, and you would see that nothing bad would happen, and your fear would then be what we call extinct. So you stay there until extinction. So the feared object doesn't then lead to these negative outcomes, and you kind of relearn that actually the feared stimulus doesn't lead to the negative response that you once thought it would. Evaluating this then, so there is research for systematic desensitization. So Gilroy looked at systematic desensitization, and they found that those that had been through that had lower levels of fear, both in the short term and long term, after going through systematic desensitization. So it does have an effect. And the good thing about this, especially comparing it maybe to flooding, is that the patients are in control, they understand the process, they can go through it, and it generally works. The issues with flooding, jumping to that bottom point there, is that actually patients might choose it, but they might not know how distressing it would be to be in a situation with their feared object, and so you've got an issue there with informed consent, and patients are not in as much control. However, with flooding generally is a lot quicker, so takes less time, is more cost effective, but that's only if the patients can see it through to the end. And actually, if it's just what we call a simple behavioural phobia, then that might not be much of an issue. But if you've got a more complex phobia where there's maybe a bit of comorbidity, they've got other disorders, or it's something like social phobia is quite a difficult one to go for flooding, because how do you stop people running away from an open environment? And so it's flooding might not be appropriate for all types of phobia, and that's another evaluation. Okay, so next we go on to looking at depression, which is a mood disorder. And again, we'll look at the characteristics, we'll look at the behavioural, emotional, cognitive characteristics, and then go to look at the explanation and treatment. And this time it will be the cognitive approach. So what is depression? Well, from a behavioural, emotional, and cognitive point of view, someone with depression generally displays as having reduced energy, their activity levels have dropped, they generally don't have the get up and go to do things. There tends to be a disruption to sleep, either too much or not enough, and again eating, there's disruption to eating, and again that could be an increase in appetite leading to weight gain, or that can be a loss of appetite leading to weight loss. And there's also often aggressive episodes. People with depression can lash out, again not always, and again self-harm sometimes is a behavioural characteristic of depression. From a cognitive point of view, and we'll look into this in a bit more detail, people with depression tend to have a lack of concentration. They can't focus on any one thing, and again that has links to the behavioural and emotional side of things. They tend to focus on the negative, so rather than seeing the positive in things, they might get a really good test mark, 88%, but they'll say, okay, well, what did I get wrong? It was really bad, not great, and really focus on the negative 20%. And they also tend to be absolutionists. So this is seeing things in kind of black and white terms. It is good or bad, rather than seeing some good in things, which other people generally without depression can do. Depression is a mood disorder, which means that it obviously has effect on mood. There tends to be a lowered mood, and again I think most people will be able to tell you that about depression. So people who are depressed tend to be quite upset and not see the best in things. There tends to be some anger and a negative view of themselves, and so that's low self-esteem as well, and it can be quite hard to get out of the thinking pattern. So yeah, we'll go a bit more into the cognitive side of things then. Really, there's two researchers you need to be aware of that looked at the cognitive explanation of psychology, and they were Beck and Ellis. So Beck is famous for Beck's cognitive triad, and these are thoughts about the world, the future, and the self. So negative, low thoughts about the world, it's a bad place, it's not a good place to be in. About the future, the thinking that things will never get better and that it's always going to be the same and there's no positive to come later on in life, and the self, so having a negative view of themselves, and again self-esteem being an issue. Beck's also concentrated on negative schemas. So schemas, again from the approaches topic, are packets of information, and so people who have depression tend to have negative schemas. They see the world through the lens of negativity, and these tend to be reinforced, and there's faulty information processing as well. So one event could happen to two different people. Someone that's depressed would would see the negative always, whereas someone who isn't might be able to see positive sides of things. And so what we call this is a faulty thought process. They're not seeing the world as it is, which is never generally black and white. It's grey areas, and some things are good and some things aren't. It tends to be that the depressed person sees the negative and nothing else. Ellis developed this a bit more with the ABC model. ABC stands for activating event, belief and consequences, and so the one thing leads into another. So Ellis's view of depression suggests that there is generally a cause, a stimulus in the environment that is the activating event. So something happens, it could be, I don't know, they're involved in a car crash maybe, or it could be the end of a relationship, and these events then trigger beliefs. So that's the A, then the B, so the beliefs. So the beliefs are things such as that to be successful you have to be perfect, that things always have to go right, and that the world has to be fair. Those are sorts of beliefs that someone with depression may have. And then the consequences are, well, when these things don't happen, this could then lead to people seeing themselves as failures, and the other cognitive things that we talk about, and lower self-esteem and lowering the mood, and it's a bit of a vicious cycle and so it's a bit of an explanation here of why someone's depressed. It's explaining the thinking and the thought processes that are going on behind that. As an evaluation then, so there is support for this idea that people with depression have different cognition. So this was Grazzoli and Terry, looked at 65 mothers who were expecting to have a child, and those that were judged as highly cognitively vulnerable. And what we mean by that is they had these thought processes, these negative views of the world and themselves and the future. So you tested them beforehand, you tested mothers before they gave birth. We could identify the cognitively vulnerable ones, and lo and behold, later on, those are the ones that were more likely to go on and suffer postnatal depression. So this isn't just a correlation. What this gives us is cause and effect. So it seems as though the thinking processes prior are the things that are having an effect on the depression later on. The kind of good part about this is the application, and so if we're aware that there's thinking processes that are going on behind depression, well, what you would need to do to try to help and treat depression is to try to help those thinking processes and try and change them, and that is CBT, and we'll go into that in a bit more detail next. But CBT has been found to work, and that supports the theory, the fact that if you ask people who are depressed to try to change their thinking and that's successful, and they do change their thinking, the depression generally is reduced and the symptoms lessen. So this supports the theory that it is the thinking that might be behind it. The other issue is that depression is quite complex, and so lots of the theories, Ellis's model in particular, seems to think that there's an activating event. Well, not always, so that would be a reactive explanation of depression. It suggests depression happens for a reason. Well, it's sometimes hard to see any one particular reason. It could be lots of little small ones, or it could be from other family issues, and when we look at OCD, there's big biological underpinnings, and there could well be to depression as well. So just looking at a cognitive approach might not give all of the explanation that we need. And as well as that, much like when we looked at phobias, there is a behavioural aspect to depression as well, and again, just looking at the thinking doesn't account for that. Moving on then, looking at treatments for depression, and following on again from the cognitive approach, CBT, cognitive behavioural therapy, is the one treatment that really stands out. Really effective for depression and lots of other mental health disorders as well. The main idea behind CBT is that the issues are identified, so the thinking patterns that we've been speaking about, the patient needs to be aware of them. So there's an interaction between the patient and the therapist to try to find these thinking patterns. They will then set goals and plan ways around the thinking patterns. So the irrational beliefs, for example, the irrational thoughts are challenged. That someone might have a thought that maybe the future's not going to be bright and there's nothing to look forward to, and evidence will be put to the contrary of this, and things will be pointed out to maybe look forward to, and so it's trying to get the thinking to change again between the patient and the therapist. Behaviour is also addressed, hence the B bit of the CBT. So they look at how people can act in different situations and how that can help. And homework is known as an important part, because it's all well and good when the patient and the therapist are together, but actually the most important bit is when the patient goes home and needs to identify these thinking patterns and challenge them at home on their own, and this is known as the homework side of things. You've also got different types of CBT based on the two researchers we spoke about, Beck and Ellis. So Beck CBT, Beck's big thing is the negative triad, the cognitive triad, the negative thoughts about the world, the self, and the future. So in Beck's CBT, these things are challenged, and as I said, they will look at things in the world and say, look, there are things to look forward to, or look at things about themselves that they can see positives in, look at the future, and these thoughts are challenged. So again, one of the depressive thoughts might be, nobody likes me, I haven't got any friends, and so evidence will be presented that goes against this thinking, and that's part of it. Ellis's side of things, type of CBT, is known as rational emotive behavioural therapy. And so this is where the ABC that we spoke about before, so the activating event, the belief, and the consequence, these are then challenged. So this turns from ABC to ABCD. So the ABCDE. So the D and the E. The D stands for dispute, and again, this is disputing with evidence, and the E stands for effect. So what effect, what outcome will the dispute have? And they're trying to stop these negative thoughts, this people thinking that everything has to be fair and that things are black and white when they're not. So these are challenged. They dispute these ideas with evidence, and then the outcome should be a better outcome and a better way of thinking, and hopefully a reduction in depressive symptoms. Evaluations then, so there is a lot of research supporting CBT and its effectiveness. So one bit of this was March et al. Comparing CBT, drugs, and a combination of CBT and drugs combined, and what they found after 36 weeks, 81% of the CBT group, 81% of the drugs group alone showed improvements, and then when they were combined, drugs and CBT, there was 86%. So this shows that even on its own, CBT is really effective, but especially when combined with drugs, which we'll look at a bit in more detail with the OCD topic. But there is positive outcomes. However, obviously, to engage in CBT, someone has to take the choice, and they have to be willing to listen and willing to change their thoughts. And sometimes people have got severe depression or are manic and can't see it. It's hard to get them into the CBT, so that's where CBT becomes difficult, because you do have to have the patient buy-in. Another point is that the therapist-patient relationship seems to be an important aspect in CBT. So if you look at CBT compared with other treatments, other what they call talking therapy, psychodynamic treatment, psychotherapy, then they seem about equitable, and that seems to be because of this relationship that the therapist and the patient develops, and that seems to be quite important. A negative is that sometimes the patient wants to take into account past experiences. So we talk about these activating events and what happened when they were children, because often depression can be stemmed from that. But actually CBT itself doesn't necessarily do that. It looks more at the current thinking and then future. And some patients feel a bit frustrated with that. And again, other therapies, psychotherapy, tends to do that a bit more. And so there's a bit of a conflict there. The other issue is that, again, we mentioned before that there is certainly behavioural elements to depression. People don't go out, there's issues with sleeping and eating and things like that, and sometimes if you don't tackle those aspects, the behavioural aspects, it's hard to change anything, and so you do need the behavioural side as well. Finally, we move on to obsessive compulsive disorder, or OCD. OCD is characterized by obsessions, which are thoughts, repetitive thoughts, and compulsions, which are actions, generally behaviors, acts, which are also repetitive. And those two things are linked. You would have thinking about something, and that would then generally trigger a behavior. So OCD kind of describes itself. So we need to look at the characteristics again. What is OCD? And as I've just said with the name, OCD does describe itself, so it's got a behavioural and a cognitive aspect. So the obsessions are the cognitive side of things, and the compulsions are the behavioural side of things. So the behavioural side of things, yeah, compulsions, they tend to be repetitive. The reason that people with OCD tend to complete their compulsions is to reduce anxiety. So they might have the obsessions, the thoughts about something. Very, very common OCDs are to do with cleanliness and safety and checking behaviour. So if you've got a thought, a repetitive thought that you're worried that your house is going to blow up and kill your family, that's a horrible thought. So you might want to do something about it. So you'll check the gases off, but you won't just do that once. You'll do it 50 times, 100 times before you leave the house. So those two things are linked. There's also, from the behavioural side of things, you'd probably tend to avoid that. So you might, if you are worried about a gas leak blowing up the house, you might avoid cooking on gas and get an electric heater to try and prevent that. You then got the cognitive side of things, and this is the obsessive thoughts. And so, yeah, cleanliness might be one. So you might be worried that you might get sick and die. So that could be an obsessive thought. And so that clouds everything that you look at. You might not like to touch door handles or shake people's hands or go on chairs that other people have gone on. So that those thoughts are saying, oh, if I do any of these things, I'm going to get ill. And then you would respond with that with, as I said, the compulsion. So you might clean consistently and constantly. But yeah, an obsession is a unwanted thought, image, or impulse. Generally, there is an awareness of these thoughts. There's an awareness that the thoughts are happening, that they are irrational, and that they don't make sense, but people can't stop themselves doing it, and that's different from some disorders. Some psychological disorders, psychotic disorders, quite often people might not be aware that they've got an issue, whereas OCD sufferers are very aware of that. And that leads to our last point, the emotional side of things. OCD is considered an anxiety disorder. It causes extreme anxiety. It's obviously not a pleasant thing to have, and it causes people a lot of distress because they're aware that they're not thinking correctly, but they don't necessarily know why. You can get what's called pure O, which is just obsessions without the compulsions, and that might cause more anxiety maybe because obviously they haven't got the release. There's also a link here to depression, because obviously if you're worried about things and you're constantly worried about things and you know you shouldn't be, that's going to have an effect on your mood, and as we spoke about in the depression side of things, that could cause lower mood and maybe lead to Beck and Ellis's the cognitive triad ABC model, for example. So, how do we explain it? Well, one of the ways that you can explain OCD is using biology, so the biological explanation, and we'll look at genetic and neural factors. So, genetic approach to OCD suggests that it's passed on through families. There's a bit of support for this. So, Lewis looked at family members with OCD and other family members. So, they looked at someone with OCD and looked at whether their parents or their siblings also had an incidence of OCD, and they found 37% of those with OCD, so a third, just over a third, have parents who also have OCD. So that does suggest a link, a biological link there, and again 21, around 20%, 1 in 5 have siblings with OCD. So it does seem that it might be running in families here. There might be some sort of genetic link. It's possible the diathesis stress model is happening here, where you might have a genetic predisposition. So someone who's got someone with OCD in their family might be more likely to get it, but not necessarily granted, because in both those examples there, more didn't have it than did. So you might be born with a predisposition, a propensity to potentially get it, but then something in the environment triggers it. So there might be a biological and environmental link here. You can look at SERT genes, which stands for serotonin transmission genes. One of these is 5-HT1D beta, and this is a candidate gene. So what that means is you're looking for a specific gene that might be linked to OCD, and that's one of them. The other approach to take, which is what Taylor looked at with a meta-analysis of previous studies. There are about 130 different genes that have been linked to it. So rather than a candidate gene, we're calling this polygenetic. So you've got lots of different genes that could potentially be linked here. And as well as serotonin here, dopamine has also been implicated in OCD. We then go down to neural, and so neural is looking more at brain regions and functioning in the brain. And serotonin is the neurotransmitter that does come up time and time again when looking at OCD. And it's thought that low levels of serotonin, so serotonin is to do with inhibition and being able to make decisions and function. So if you've got low levels of that, you might not be able to process that properly, and so you might not be able to stop yourself from having these thoughts and actions. There's also areas of the brain, so the frontal lobes, which are linked to decision making, and if there's maybe damage or disruption in that area, that has also been thought to be linked to OCD as well. The support for this evaluation, some support, some criticism. So Nestad et al., they conducted a meta-analysis of twin studies. So this is again looking at, is there a gene, is there a comorbidity? And you look at monozygotic and dizygotic twins. Monozygotic have 100% of the same DNA. And what you find when doing a meta-analysis, 68% of monozygotic twins, if one had OCD, the other also did. That's known as the concordance rate. 68% concordance rate, that's really high, and that again supports the idea that genes have a role to play. And the fact that that's higher than the dizygotic twins, who have only 50% of the same DNA, again supports this idea that the more genes you've got in common, the more likely you are to get the disorder. The issue with twin studies is that, and you could use this as a counterpoint, a double Whopper burger paragraph, is the fact that obviously identical twins might share more of a similar environment than non-identical twins. They might have the same, be dressed up in the same clothes as their parents, same friends, same bedroom, where non-identical twins might not have that, and so it's hard to tell how much of that increased percentage is due to the genes and how much is due to the environment. That's a problem. Cromer suggested as well, so this is a criticism really of the biological approach, it suggests that environment does really have a role to play. More than 50% of OCD sufferers have a traumatic trigger, so you can point at something in the environment and say, look, this could have set it off, which suggests that it's not just biological. It is maybe that diathesis stress model that we spoke about before, where you've got a biological propensity, predisposition to having OCD, but then something needs to trigger it. There's also research that suggests that expectant mothers, they're more likely to develop their OCD after they've given birth, and the idea here is that obviously once you've given birth, there's someone else you're responsible for, and you start worrying about them, and again cleanliness and protection sort of thoughts kind of take over. So it's this two process model. So genes do seem to have a role to play, but it's hard to say what role environment also has. Looking at the neural side of things, the biggest strength for the neural explanation, especially the serotonin explanation, will come next when we start looking at treatments. But by far the most popular and effective treatment for OCD is SSRIs, which stands for selective serotonin reuptake inhibitors. And they work, they end up allowing a greater amount of serotonin to be transmitted across synapses. And so the fact that if you increase the amount of serotonin available, conditions and behaviours, the obsessions and the compulsions reduce, that adds support to the idea that serotonin really does have a role to play in OCD. The issue we have here is that it's cause and effect. So we don't know whether these lower levels of OCD, whether someone's gained OCD, for example, or there's more of a environmental explanation. Someone's been in a stressful environment, say the mothers I just spoke about there, and they then start having that thinking pattern and those behavioural patterns, that could then change the levels of serotonin. So just because you see low levels of serotonin doesn't mean there's cause and effect there. It could be the other way around. It could be that serotonin is causing the OCD, or it could be that the OCD is causing the lower levels of serotonin, or it could be a third variable. So this is the issue with, it's essentially a correlation. We don't have any cause and effect. So you do need to take into account the cognitive, the thinking, and the behavioural side of things to OCD as well. Right, finally then, let's look at treatments for OCD. And as I've already just mentioned, selective serotonin reuptake inhibitors, these are the treatment of choice, and they are effective. Look at in the evaluation in a second. So what selective serotonin reuptake inhibitors do, that's a mouthful, is prevent the reuptake. And what reuptake is, you might need to go back to your biopsychology just to remind yourself of this. But when a neurochemical is passed between neurons, it's released from the sending neuron into the synaptic cleft, and a process called reuptake happens where the neuron that sent the message takes some of whatever neurotransmitter it is, and we'll talk about serotonin here, takes some of it back to store it for the next time. What an SSRI does would prevent that reuptake, which means that there's more serotonin available in the synaptic cleft, which means the receiving neuron could potentially receive more than they would otherwise. So it's not actually technically increasing the levels of serotonin in the body, it's just making them more available. And what the usual treatment is, 3 to 4 months of 20 milligrams of fluoxetine. That is generally what GP, NHS, NICE guidelines would suggest. Quite often this occurs with CBT as well, so you'd have maybe some cognitive behavioural therapy. There are other treatments available. Tricyclics are more known for antidepressants, but if maybe the selective serotonin reuptake inhibitors, so again, don't work, then you would try the tricyclics. The reason why you would choose the selective serotonin reuptake inhibitors over the tricyclics is because there's fewer side effects with the selective serotonin reuptake inhibitors. The tricyclics tend to have more side effects, and so that's a negative. The other one would be serotonin noradrenaline reuptake inhibitors, which are, again, they are similar, but obviously have an effect on another neurochemical called noradrenaline. But both of these systems are thought to have an effect on OCD, and so that's why they're given. And again, they have been found to work. So evaluation, Samaro et al. Looked at the difference between an SSRI and a placebo. Placebos, for those that don't know, is where you give people sugar pills. They think they're taking pills, they're not. The reason we give those is as a bit of a control. Is it just a mental thing, or are these pills actually working? And what you found was a 70% reduction in OCD symptoms with the SSRI group rather than the placebo group. So it really does look like it's not just a thought thing. Actually having an impact on the serotonin levels of individuals does have a positive effect in reducing the symptoms of OCD, which is good. The reason it's good is because this is more cost effective. So if you give someone drugs, it's generally cheaper than paying a psychologist or someone trained in CBT to deliver that. It's quicker as well. It happens, as I say, in a couple of months, where CBT could last longer, even years. The issue is, as I mentioned before, there can be side effects in SSRIs, even SSRIs, and that would put people off taking them. So if you lose your vision or you lose your sex drive, you're probably not going to be so keen to carry on taking them. So it's a bit of a balancing act. And if you do just take the drugs rather than the drugs and CBT, you're still going to have, if you stop the drugs, you're still then going to have maybe the underlying causes, which could be the thinking processes or the environment. And so what's best is doing the SSRIs and CBT, because then hopefully you're changing the thinking and the behaviour. I thank you very much.